Here we go. Okay, so you should all be able to see now in front of you Jack's first slide. Jack is Dr. Jack Lambert, is a consultant in infectious diseases and has a specialism in Lyme and COVID and long COVID, and is certainly not a stranger to us at Napiers the Herbalists. And we've worked with him for quite a long time. Jack has very kindly agreed to give us an hour of his time tonight. He will be going through a 30-minute presentation, then we'll do some questions and answers. So over to you, Jack. Thank you very much.
Okay, great. So good evening. So I think my slides are in front of me here, but just as an introduction, as stated, I've done infectious diseases for about 35 years now, both adult and pediatrics, and I'm currently located in Dublin, Ireland. So I manage all infections from hepatitis to COVID to HIV to tropical diseases. But in the last 10 years, I just became aware that Lyme disease was a problem in the European Union. Having trained in America, I saw a lot of it there, but never really thought much about it when I came to the UK and Ireland. But it's becoming increasingly recognized. And then, so I'm going to just talk a little bit about Lyme disease and about chronic Lyme disease and maybe a little bit of the similarities. But anyway, back in 2020, we were in Ireland. We were the first to see the COVID patients, and then many of our staff got long COVID and it didn't recover. And I kind of put the connection between the signs and symptoms of people with chronic Lyme and long COVID, and I adapted a lot of my protocols that I've used to manage the symptoms of chronic Lyme to patients with long COVID. So anyway, without further ado, I'll get on with my slides and hopefully just whirl through them, focusing a little bit on Lyme, mostly in long COVID, give you my approach to managing these patients, and then we'll leave time for questions. So, so the title is Understanding Lyme Disease and Long COVID. Let me see if I can move my slide. And the term long COVID, or people used long COVID, it was actually a doctor who got COVID himself and didn't recover. And the definition of long COVID that most people use is if you get COVID and 3 months later you still have symptoms, that's long COVID. And then some people continue to be unwell years, 2 years, and we now have data 3.5 years down the way of people with COVID. But going back to early on in COVID, this is kind of a publication that we have from the Mater Hospital in Dublin, the first 100 patients admitted to the Mater Hospital. And if you look at the symptoms, we used to think that COVID was a disease that affected the heart and lungs, but a third of the patients had neurological problems, headaches, reduced consciousness, and about a third of them also had intestinal symptoms, abdominal pain, diarrhea, nausea, those kind of symptoms. So COVID is a virus that affects more than just the heart and the lungs. It affects the whole body, very similar to Lyme disease, which disseminates from a tick bite to every part of the body. And then this is kind of a CDC description of all the different signs and symptoms of long COVID, from fatigue, muscle aches, difficulty sleeping, headaches, cough, joint pain, palpitations, diarrhea, night sweats, all the different symptoms. And there's many more symptoms than that as we move forward. And then if you look at Lyme disease, you start to see some of the overlap in terms of the signs and symptoms: facial palsy, palpitations, chest pain, shortness of breath, anxiety, cognitive dysfunction, neurological problems, neuralgia pains, nerve pain, etc. And then if you don't treat Lyme early, the later symptoms become a lot more similar to those of long COVID: myalgia, tendon pain, neuropathic pain, air hunger, sleep disorders, fatigue, dizziness, cognitive problems, psychiatric problems. I say neuropsychiatric problems, and then dysautonomia, POTS. So this is very similar, as you've seen, to that. And even if when you treat people with Lyme disease, this is a slide showing people who were treated, but still evidence of infection. They didn't get better. And the Americans like to call this PTLDS, post-treatment Lyme disease syndrome, kind of implying there's no infection there. But sometimes there is infection, and they have a lot of the same kind of symptoms: fatigue, arthralgias, neurological problems, headaches, tremors. So a lot of similarities between, in my understanding of COVID and chronic Lyme. And then just when people debate, is there persistent infection following standard treatment for Lyme disease? And the answer is some people still have evidence of infection that responds to antibiotics. And this is a wide range of case histories, animal studies, xenodiagnostic studies, and clinical trial studies shown persistent infection and response to treatment even after they've been treated before. And people will have access to my slide presentation at the end of this. So you can, I'm whipping through this, but if you want to look at the slides at your leisure, you're welcome to do that later. And then I just saw something from Regmore in Scotland recently saying, oh, ticks carry more than just Lyme. And it's like, yeah, we know that. We've known that for 10, 20 years. So Babesia, Anaplasma rickettsia, there's now tick-borne encephalitis in the UK. Ticks carry lots of different bacteria, and this is a list of some of the bacteria, viruses, other organisms that ticks carry. And just anecdotally, my experience is about 10% of the patients I'm seeing that got a tick bite, got a rash, their test was negative for Lyme. They probably do have Lyme, but they also had anaplasma as well. So the other infections besides Lyme. And then this is the big tick projects. This is the distribution of ticks in the UK and Northern Ireland. And there are epicenters in the north of Scotland and, you know, the east part of England and southwest. But every place in the UK and Ireland have ticks. And some of those ticks are infected. And some people are getting infected from those ticks. In Ireland, I get tired of hearing no ticks, no Lyme. In Ireland, we did a study, we picked the ticks, we did PCRs on them, and between 5 and 15% of the ticks are positive for Lyme in Ireland. And if you go to Twickenham Part in London, as many as 8% of the ticks are positive for Lyme. So ticks are everywhere. And then the testing, we say the testing is great. Well, these are the studies. The testing isn't that good. 36 to 70%. So I have lots of people that say, well, you don't have Lyme because your test is negative. But then my opinion is the test is at best is 50-50. So you have to use your clinical judgment to diagnose Lyme disease. And people go abroad and get other tests done, and they say, we don't accept foreign tests because the tests are not accredited, the laboratories are not accredited. They are accredited. Many of the tests that the UK and Ireland do are not accredited tests. So any suspicion of Lyme can be helpful. Any test, positive or negative, can be helpful in terms of Lyme. And then moving on to treatment, if you catch Lyme early, the NICE guidelines are 21 days of doxycycline or amoxicillin or azithromycin, and then sometimes repeating another 3 weeks course if you get better or you don't respond to the initial therapy. In Ireland, most of my colleagues say 2 weeks of doxycycline and everybody's cured. And it doesn't make sense to me because lots of people respond to doxycycline, and then when you stop the doxycycline, their symptoms come back again. That to me says the infection hasn't gone. But most of my colleagues say the infection's gone. And my response is, why did you treat them at all in the first place if you evaluate a clinical response and are not willing to retreat them like you do for every other infection? Cellulitis, we retreat. Ear infections, we retreat. But this is the standard guidelines for treatment. But if you actually don't diagnose Lyme early on, these are a number of studies, 4 of them, that show 25 to 71% of patients who you treat with short-term antibiotics with later stage disease. Some patients get a tick bite, get a rash. They're not treated. A year later, they get joint pain. Lyme is in those joints, and 2 weeks of doxycycline doesn't cure people. So you sometimes have to treat people longer, even though people say there's no evidence that longer course treatment works. And this is a publication we have out of Dublin, where we had analyzed 301 patients who were sick for over a year with Lyme. So I call that partially treated Lyme, with a combination of treatment, treating Lyme and the co-infections. About 70% of people got better, improved on treatment for long-standing Lyme disease. So there is evidence that longer course treatment can help people, but it is more complicated in that situation. Just moving on to a study we had from the Mater Hospital looking at COVID and long COVID. We followed up patients with long COVID. I got a grant from the Irish government because you saw long COVID coming. If you go back to the days of SARS and the days of MERS, there were patients who got SARS who never recovered. They had chronic fatigue 20 years later. So people saw it coming. And this is just a study by the GPs in Dublin on the cohort that I put together, looking at mental health on these patients a year after they got their COVID. And even a year down the way, 18% of them still had, depression, anxiety, PTSD, and some of them were actually inappropriately seeking alcohol. So this doesn't say that they had psychological problems. This to me says that long COVID sort of generated kind of neuropsychiatric manifestations. And these are some of the manifestations. And we'll go into the pathogenesis of those in a few minutes. This is another study from the Mater where we looked at 295 patients who were admitted to the ICU or the HDU, very sick with COVID. And this is looking at EBV reactivation, CMV reactivation, zoster reactivation, herpes reactivation. And in the ICU, some patients who had COVID, not transplant patients, not AIDS patients, were getting EBV reactivation by PCR. And this was associated with low lymphocyte counts. And this is just another study looking at CMV, another slide looking at CMV virus reactivation. Some of the patients that had CMV virus reactivation were immunocompromised, but some of them were previously immunocompetent, and they became immunocompromised as a result of COVID affecting the lymphocytes, okay? And then this is a slide looking at zoster and herpes outbreaks in these patients. And about 10% of these patients had that, and it was associated with low lymphocyte counts. Moving on, I said the big problem, I think, with chronic Lyme and with long COVID is the brain. And this is PET scans looking at the brains of people with long COVID. And just to summarize, there were clusters of hypometabolism in the posterior parts of the brain, the parts of the brain that control where your pain center is, your respiratory center is, your cranial nerves come out of the posterior part of the brain, your pons medulla is there, your balance center is there, your autonomic nervous system runs out of there. So there are areas of abnormalities, and people kind of say, well, your brain scan, your CT is normal, your MRI is normal. This is all psychological. It's not. It's neuroinflammation. And this is a PET scan out of Hopkins on patients with chronic Lyme. And they took 12 patients with PTLDS, people still sick despite being treated for Lyme disease. And they found abnormalities in the same parts of the brain, the cerebellum, the frontal cortex, the parietal cortex, the thalamus, the temporal cortex, the parts of the brain that are controlling the same symptoms. So there's similarities in the brain pathology of patients with chronic Lyme and long COVID. So anyway, well, we're going to put Lyme aside, but I do want to kind of mention the similarities. I know the difference, obviously, Lyme and co-infections is a bacteria. Are bacterial infections. So antibiotics have a huge role in the treatment of patients. With COVID, long COVID, it's the virus. And sometimes, usually we think the COVID virus is gone. But who progresses to long COVID? The answer is anybody can, not just those hospitalized. It could be those in the community. You can have mild symptoms and get long COVID. There is some minor protection from getting a COVID-19 vaccine, but not significant. So anybody can get long COVID. And moving on to the pathogenesis of long COVID, back in 2020, we thought the heart and lung would be the thing that would be infected. I thought we were going to have patients with cardiomyopathies and pulmonary fibrosis, but as a rule, the lungs heal. And back in early 2021, studies coming out saying it's the brain, it's neurological manifestations, it's neuroinflammation, it's inflammation of the blood vessels, maybe microclots. It's the problem with long COVID is the brain. And interestingly, kind of a study from Scientific America 2023, long COVID now looks like a neurological disease, focusing on treatment. But to this day, many of the clinics in Ireland, I can tell you, are run by infectious disease doctors and pulmonary doctors and cardiology doctors, who basically, if you've got air hunger from long COVID, which is a central process, the respiratory centers in the brain, they're getting CTs, pulmonary function tests, they're getting sleep apnea tests, they're getting put on CPAP, because that's what pulmonary doctors do. And I keep on saying, it's the brain, dummy, not the lungs that are the problems. So it's taken a long time for people to catch on. So my summary of what the pathogenesis of chronic Lyme long COVID is. With chronic Lyme, I teach people it's the 3 I's: infection, which triggers inflammation. And then if it's in your system long enough, you get a damaged immune system. Many of my patients with chronic Lyme have low lymphocytes, similar to HIV/AIDS patients. With long COVID, we add a few more things. It's not a bacterial infection, but sometimes as a rule, the COVID virus is gone. We don't think there's residual virus triggering the symptoms, but everybody has endogenous viruses, DNA viruses, EBV viruses, CMV virus, herpes viruses, zoster viruses, and those viruses can reactivate and contribute to symptoms. So virus reactivation can happen in long COVID. There's brain and nervous system inflammation and the autonomic nervous system. There's immune dysregulation. The mitochondria is affected, mitochondrial dysfunction. And then there's blood vessel inflammation, microclots. One of my patients called it sticky blood. So you just get not enough blood flow to the tissues of the body. And this can be contributing to the symptomatology. When I went to prepare this presentation, I did a PubMed search, and I found this interesting article in Virology. And what they did is they did a PubMed search and a meta-analysis of all the different studies on treatments for long COVID. And they looked at metformin, LDN, dexamethasone, omega fatty acids, arginine. They looked at IVIG, apheresis, and early findings suggest that metformin was one of the strongest, drugs that clinical trials have showed benefit, and LDN dexamethasone had potential benefits in observational studies. But the challenge is there's been lots of pathogenic studies, but very few treatment studies. So this study then that analyzed 7 different areas. They looked at antihypertensive, ADHD treatments. They looked at antioxidant studies. They looked at anti-diabetic studies with metformin. They looked at immune modulators, including LDN, IVIG, dexamethasone, and then looked at some other studies that have been done using omega-3 oils, L-arginine, vitamin C, and they looked at some other immune modulators that are going on. And I'll just kind of give you the analysis of some of them. Pathogenesis of long COVID, according to the study, like we've talked about this already, hypotheses under investigation include immune dysregulation, virus reactivation, endothelial damage, persistent inflammation, autoimmunity, viral persistence, dysautonomia, microbial dysregulation, dysbiosis. There is data that if you get COVID and you take an antiviral against COVID, it can reduce the occurrence of, long COVID by about 25%. This study then looked at 2,000 articles, excluded 114 that were antiviral, filtered through 1,900, and they come up with only 18 articles. And as I said, of these studies, metformin stood out with the strongest evidence. The challenge, though, is metformin only works if you catch it after you get COVID, before you get long COVID. Dexamethasone also shows benefit similarly, only if you catch it when you have COVID, and it reduces the risk of long COVID. Other studies, omega-3 fatty acids showed improvements. L-arginine combined with vitamin C showed some improvements. And then other studies looking at therapeutic apheresis, where you actually filter out the bad antibodies. In a small study, 27 patients showed some benefit. Intravenous immune globulin, which is used for lots of immune diseases. It's used for kids with PANS, PANDAS, neuroinflammation, neuropsychiatric manifestations. pilot studies have shown improvement in fatigue, cognitive function. N-acetylcysteine has shown improvements in 67% of patients, but about 25% patients had trouble with tolerating it. And then moving on, guanfacine, which is kind of similar to Ritalin, in combination with NAC, showed benefit in addressing brain fog. NAC, as I mentioned, looks like it's beneficial in replenishing intracellular glutathione, protecting the neurons. And LDN has shown, at least in some 6 different pilot studies, shows benefit in reducing brain fog, fatigue, and it seems to work through some immune modulating effects and anti-inflammatory effects, and actually works on the brain receptors. And there's been studies looking at LDN in patients with atypical MS, where they have funny neurology and funny white spots on their MRI scans. And after LDN treatment, their funny neurology disappears and their brain scans go back to normal. So it's doing something. Additional studies on coenzyme Q10 in terms of supporting the mitochondria, studies on IVIG working on neutralizing autoantibodies and modulating immune responses. And then we mentioned apheresis, which is removing some of the inflammatory cytokines and autoantibodies that might be contributing to immune dysregulation, chronic inflammation. Dexamethasone, we've mentioned this before. Omega oils seem to have certain benefit. One of the subgroups of omega oils, EPA, is involved in reducing inflammation. Metformin is an anti-diabetic medication, helps if administered early. And there's one study looking at kind of a nutritional blend called Immune Recovery that seems to modulate immune responses, managing cytokine-mediated damage in long COVID patients by changing some of the cytokine profiles, decreasing IL-6, increasing IL-12, IL-6 being a bad interleukin and IL-10 being a good one. So there's a number of pilot studies out there showing benefit. Vitamin D seems to have some benefit, and there's some observational studies showing that lower vitamin B levels are, it isn't good. And then melatonin obviously is one of the sleep hormones that have activity in restoring circadian rhythms that can be disruptive in long COVID. This is a study that we actually did. The first study that was done on LDN was actually a study from my group in Dublin. About 60 of my nurses just never recovered. I'd used LDN before in chronic Lyme patients, and we just did an observational study of about 60 patients who just hadn't recovered after a year. And these were fit, healthy, mostly 30-year-old super nurses working 12-hour shifts, running marathon, raising 3 kids, super moms. And they just couldn't make it back to work. And within 2 months, so what is LDN? It's an opiate receptor antagonist. And like I said, it's been used before by doctors in different disease areas, gastroenterologists, et cetera, neurologists, rheumatologists. And within 2 months of starting the LDN, about 80% of people improved. Questions asked: I've recovered from COVID. Is my health better? Do I have better energy? Is my mood better? Is my pain less? Is my concentration better? Is my sleep better? So it seems to help, okay? It's not the magic bullet, but it works on 2 of the major areas of long COVID, which is inflammation and immune dysregulation. So my summary of long COVID manifestations, and I'll talk a little bit about my approach to treatment, is there's deficiencies of multiple different, zinc, selenium, coenzyme Q10. There's no one magic pill that's going to get you better. Probiotics have been shown to speed up recovery from COVID-19. Your gut is your immune system. 80% of your immune cells are in the gut. Inflammation and autoimmunity is a problem. Damage to the mitochondria problem. Microclots, sticky blood can be a problem. Reactivation of other infections can occur with DNA viruses. And then besides brain and nervous system inflammation, we know that the cranial nerve smell and taste, cranial nerve 1 and 2 can be affected, but then cranial nerve 5 can be affected. cranial nerve 10 and 11, the vagus nerve that runs into the chest, into the gut, can be affected as well. And then the sympathetic, parasympathetic system, POTS, dysautonomia, can occur as a function of nervous cell inflammation. So what helps? And there's no one thing that helps. And this is where complementary medicine comes in to play. There is not one thing that helps somebody with 100 different symptoms with 5 different pathogenic mechanisms. But lifestyle counseling can help. Diet helps. Sleep, stress management can help. Interventions to target the brain and cranial nerves can help. Interventions to repair the immune system. Interventions to target the mitochondria. Interventions to target vascular inflammation and microclots. Those are the things that can be done. I was given a list of home exercises early on by one of the Olympic rowers in Ireland, and she put together her own plan in 2020. She was bedridden. And here in 2024, she's back to her same cardiovascular fitness by working on repairing the diaphragm, by repairing the vagus nerve, by repairing the sympathetic parasympathetic system. So there are things you can do for neurorehabilitation. Post-exertional malaise is a significant problem, and most of the clinics I see patients coming from still have physiotherapists, who are respiratory physiotherapists saying, rah, rah, do more. And don't do more because you crash. And, and this study from the Journal of Transmed basically said clinicians should not force their patients to increase their activity and should instead encourage them to stop, work, and rest. And pushing them can cause physical and emotional harm and sometimes irreversible damage. And I'm willing to go to court for anybody who's been pushed into crashing, okay? So pacing is the critical concept. And there's a clinic in Ireland called the Bree Clinic, run by a really good occupational therapist. America has a Visible app that you can use to kind of manage your energy limiting illness. And there's some cardiorespiratory physiotherapists that teach people how to safely start doing more. And you'll have copies of these slides if you want to look up these references. Now, as I said, multiple different multivitamin supplements can be used. There's no one supplement or vitamin. It's not just arginine. It's not just vitamin C that will fix long COVID. So I usually advise some people go on a multivitamin with coenzyme Q10. In Ireland, they have products called Revive Active that have multiple different ingredients. And then I've worked with Napiers in Scotland who put together a number of products, including Sublime Vitality, that has many of the ingredients that, at least in pilot studies, look like they're benefiting patient. This is Sublime Vitality, which is a powder formulation with 34 different ingredients, including lots of the things I talked about that can benefit people. This is another product called Sublime Essential Capsule that has it's a capsule that has a number of different products that help with the mitochondria, has NAC, helps with inflammation, helps with the immune system, helps with the mast cell release. So there's a number of different products that can be used. And some people take these products individually, but this product has a number of different products that help with some of the issues, the pathogenic mechanisms of COVID. N-acetylcysteine can assist with crashing. As I mentioned, it's in a number of different multiple vitamins. Sometimes people can't take the multiple vitamin preparations. You can get NAC as a single tablet. NAC is converted to glutathione. Kids who are born with mitochondrial deficiencies are put on NAC so that their muscles don't turn to jelly. And there's pilot studies showing NAC provides benefit. So management of long COVIDs, lessons from Lyme, which are similar characteristics. Infections trigger a cascade of disseminated spread, to multiple organs. If it's Lyme disease or co-infections, it's through the bloodstream. If it's COVID, similarly, it's through the bloodstream. These organisms or proteins from dead virus, get into every tissue of the body. There's a cascade of inflammatory and autoimmune process. Some viruses that you have in your body, when your immune system will go down, reactivate. Epstein-Barr virus, CMV virus. As I said, patients are often lymphopenic with deranged lymphocyte markers. If you're lymphopenic, you get reactivation of these infections. If you're lymphopenic, lymphocyte CD4 cells modulate your immune cells, your allergic response, your mast cell response. So management must address the issue of persistent infection, deranged immune system, immune crashing, sticky blood, neuroinflammation, autonomic service inflammation, cranial nerve inflammation, and critically, pacing, not pushing, don't advise grading exercise. And this is just my suggested protocol: a multivitamin, a probiotic, something that provides mitochondrial support, LDN, with slow titration up, 1 milligram up to 4.5 milligrams slowly. And sometimes people's maximum doses too. For sleep disturbances, melatonin preferentially. For mood problems, sometimes you need to get people through this difficult time, low dose serotonin. For mast cell problems, H1 blockers, and some of the sedating antihistamines, if you give them at bedtime, they also work to help with sleep. Vagal nerve exercises, TENS machines can help with retraining the autonomic vagal nerve system. In select cases, low-dose aspirins, nattokinase. And then in some situations, people consult with herbalists, and there's a role for many of these products: Mangiferin, Cryptolepsis, Chinese, herbal medicines. And then people are looking at medicinal mushrooms for their immune modulating and CNS effects. And hyperbaric oxygen has been proposed. There's pilot studies showing that it benefits some, and then intravenous immune globulin and apheresis. So what should the future look like? We should have national centers for neuroinflammation that manage long COVID, long Lyme, ME/CSF, because there's similar pathogenesis. There should be guidelines for support to GPs, which there aren't, because GPs are just kind of putting band-aids on the problem. Your heart's going too fast, put you on a beta blocker. You've got nerve pain, put you on amitriptyline. Well, that has a lot of collateral damage. There needs to be pathways for management of all patients with long COVID. And there needs to be support. In Ireland, patients are not supported in LDN, melatonin, NAC, in many of the regions. They should be provided by the government. And most patients know more about, unfortunately, long COVID than many of the staff that I see running the clinics. You just need to do a PubMed search. It's the brain. That's the problem. Pacing is important. Decreasing inflammation is important. Repairing the immune system is important. Neurorehabilitation is the important concept. And then finally, I established the Lyme Resource Centre in Scotland. We have a signage project. We've put over 1,000 signs in Scotland. We're putting hundreds of signs in Ireland to make people take aware. So if people are on the call today, and prevention is the best intervention, don't get a tick or catch it early. And then the other prevention message is wearing a mask, because in the right setting, you don't want to catch another COVID infection. You don't want to catch flu. You don't want to catch RSV or other infections, because once you've got COVID and long COVID, you're more prone to repeated infections, worsening infections, and destruction of your immune system with time with repeated infections. So it's complicated. Thank you. So I think that's my slide presentation.
That was wonderful. Go on, Jack.
I'm going to see if I can close my presentation out. Okay.
There we go. Okay, well, that was very, very, I think everyone would have enjoyed that and found that very interesting. There was so much information in there. So I should say, tomorrow we will be sending out an email to everyone who signed up for this, and we will be it'll have a link on it that you can rewatch the video. So don't worry if you've missed anything that you didn't think you got tonight. You will have a chance to do that. We've got Jack now, Dr. Jack Lambert now, for some questions. We can't answer any questions about individual medical conditions. We've got some questions from lots of questions that came in before the session started. So we're going to try and work our way through that. I think one of the things, Jack, that I was getting very strongly from everything you were saying there was that this really, these, you know, both Lyme and COVID are kind of whole body assaults happening for people. It's not a small thing, right? It's very significant for many people.
Yeah, absolutely. And I think Lyme is downplayed and long COVID is downplayed, and people don't even question, the existence of chronic symptoms of Lyme 5, 10 years later. But it's multi-organ, multi-system, it's a multiple assault of many different organs and mechanisms of action. And I've learned a lot actually, like when I first managed chronic Lyme patients, I didn't focus as much on I didn't focus as much maybe on the sympathetic parasympathetic system, the parts. I didn't focus as much on the mitochondria. I think there's Lyme is such a political subject. There's no research on Lyme because you can't do research on Lyme because you can't get funding. You can't even get published. People reject your publications. But with long COVID and long COVID, there's been hundreds of millions of money put into research. So there's a lot of parallels, and we've learned a lot about chronic Lyme by the studies that have come out on long COVID.
So on the subject of Lyme in the UK, now a question that came up quite a few times was, can Lyme be successfully diagnosed in the UK? And I think that probably speaks to a lot of people's experience of trying to get diagnosed with Lyme. So, or trying to find out whether they've got Lyme. Could you talk us through what the diagnostic procedures in the UK are like right now?
Right. Well, the challenge is that, okay, if you go out to the Scottish Highlands in summer and you pull ticks off yourself and then you get a flu-like illness and you get aches and pains all over, top of my list is Lyme disease. But the situation in the UK is, well, you didn't get a bullseye rash. Everyone gets a bullseye rash. Well, no, not everybody gets a bullseye rash. Maybe if you look at studies, 37% of the people get the bullseye rash. Okay, so it's not 100%. And if you got a tick bite in your back, you might not notice the bullseye rash. So this is the challenge. People kind of say, you can't have Lyme, you never saw the tick. Only 15% of people see the tick. The tick is the size of a sesame seed, If it's in your scalp, you wouldn't see it. I had a electrical guy who went up the pole, and he was taking a shower and he was washing in his butt crack and he thought he had a zit there and he pulled out a tick. And he put it in a jar and brought it to me live. Oh, anyway, but the point is that if he hadn't been in the shower, washing his butt crack, he wouldn't have found the tick. So the challenge is that people have these preset notions, and even a lot of my clinician friends, you never saw the tick, you didn't get the bullseye rash, and then finally, the antibody testing is at best 50-50. So, you don't need an antibody test to detect Lyme, but even today, facial palsy, summer flu, joint pain all over in a previously healthy person who went out to the Isle of Mull, the last thing in people's radar screens seems to be Lyme disease. So I think that really is the challenge. And people have preset notions that I've had patients that even did have a bullseye rash and they were denied treatment because their Lyme test was negative. So we've got a big upscale, I think, in terms of educating those on the coalface, the primary care doctors, pharmacists, others that, think of Lyme, and also for patients to think of Lyme.
So there you go. Doctor's advice there to ensure we all wash our butt cracks when we're in the shower. Now, if I was suspicious that I had Lyme disease, just talk me through where would be my go-to, and what would I be having antibody blood tests or?
Right. Well, yeah, I think you should. That's the thing is that, but the issue is that in UK and Ireland, it's kind of viewed as a rare disease. Okay, it's a rare disease. The UK say, oh, maybe 2,000 cases a year. Ireland, they say maybe 100 cases a year. Well, interestingly, 5 to 10% of the ticks in UK and Ireland are positive for Lyme. 5 to 10% of the ticks in France are positive for Lyme. France is active surveillance. So France reports 80,000 cases a year with a tick burden of 5 to 10% infected with Lyme. We report 2,000 in the UK and 100 in Ireland. Well, we either have bad, epidemiological data, or maybe ticks just like to bite French people. Well, so one or the other. I think we under recognize how common Lyme disease is and other co-infections. So I think it needs to be on people's radar screen. And if you get the classic bullseye rash, then that's great. But less than 50% of people get the classic bullseye rash. It doesn't always look classic. And I see more patients go to GPs and they get treated for cellulitis with a round rash with flucloxacillin, which is good for a cellulitis caused by strep or staph. But it doesn't do anything for the bullseye rash of Lyme disease. So I think, like I said, education on the coalface is really important. But if you think you've got Lyme disease, you should ask your GP for a test. The challenge is I have more patients saying, I asked my GP for a test and he laughed at me or he refused. So I think we have to overcome that negative connotation of Lyme disease in the healthcare system.
So in this situation where I've been to Isle of Mull, I don't necessarily have a bullseye rash, but I'm exhibiting symptoms or I'm highly suspicious that I got bitten by ticks. Would a course of the correct antibiotic be advised in that situation, or?
Well, if I didn't have an alternative explanation, I very often do give a course of doxycycline. But the guidelines say if you have a bullseye rash, then you treat. But if you don't have a bullseye rash, even if you get tick bite and there's no bullseye rash and you get joint symptoms and flu afterwards, wait and do the antibody test. But I've seen people negative antibody tests at 3 months, negative at 6 months, negative at 9 months, and they went positive at 12 months. And they're crawling around for 12 months without a diagnosis, because the antibody test didn't go positive. Sometimes it doesn't go positive at all. Sometimes it goes positive and then it drops off negative. And if you look at the UK reading, even when you do get a positive test, if it's a weak positive test, they say it's a false positive. Why is it not a weak positive rather than a false positive? And then sometimes it's read, you have been exposed to Lyme if you have a positive antibody test. You've not been exposed to Lyme. You've been infected with Lyme. If you have a positive test for syphilis, you don't tell the patient, you've been exposed to syphilis. You go, you've been bloody infected with syphilis. You need treatment. The same kind of standard should hold for Lyme disease. So there's a lot of kind of misinformation, I think, out there about Lyme disease. Don't hang your hat on a Lyme test. If it's positive, it means you either have the infection or you had the infection in the past, and you can't tell the difference. And I've got a low threshold for treating people with antibiotics because it's curable, it's reversible.
Great. So moving on to actually treatment and recovery from Lyme disease, and I'm hoping you can give people some positive hope here. Do people actually recover from, this was a question that came up quite a bit, do people actually recover from Lyme disease, or does treatment just push it into remission?
Right. Well, antibiotics kill bacteria. So if you catch it early, you've got a better chance of curing people. I told you the studies that late Lyme disease, only 30% of people get cured with 2 weeks of doxycycline. I saw a priest from the Wicklow Mountains. He's a film director this spring. He saw one of our signs on tick prevention, and he got a bullseye rash, went to his GP, demanded doxycycline. He had a really horrible meningitis, headache, felt poorly, but got started on antibiotics within a day of him seeing the bullseye rash. He was sick as a dog for a week with a viral meningitis. He came to see me 2 months later. He'd received 3 weeks of doxycycline. He was cured, because bacteria can be killed with antibiotics. Now, if it takes 2 years to diagnose you, at that stage, I think the bacteria is embedded in the tissues. It's no longer in the circulation. There's lots of damage to the immune system. There's damage to the autonomic nervous system. There's inflammation. There's autoantibodies. It's more difficult. And there's a theory that Lyme goes into biofilm, goes deep into the tissues, and it's hard for the antibiotics to penetrate. But my understanding is if you treat properly and you do the right treatment and repair the immune system, you can cure Lyme. people talk about remission. I'm in remission. This is not cancer remission. You can cure Lyme, but not everybody gets cured with the antibiotics. Sometimes I think what happens is the infection is 90% cured, your immune system recovers and you're controlling the infection. And then 5 years later, I've seen this happen, you get COVID and then, bow, everything comes back again. And then you put people back on antibiotics and they get better again. So you don't always cure the infection, but you can cure bacterial infections if you treat properly.
And it's interesting to hear you mention there the biofilm, because that was something that came up as a question as well. If we now know how to treat persisters, dissolve biofilms, and cysts, why does treatment still fail for people?
Well, because most people aren't given that. Most people I see are given 2 weeks of doxycycline or 3 weeks of amoxicillin. They're not given,
Enough.
the enough treatment. And my experience is that, look, there's studies to show there's a condition called late Lyme arthritis. A year later, after the tick bite, you start getting swelling in the joints. And today, if you look at the Journal of Rheumatology, a guy called Steer, who was the rheumatologist who described Lyme in Old Lyme, Connecticut in 1975 at Yale University, he treats people with late Lyme arthritis with 2 weeks of doxycycline and 2 months of IV ceftriaxone. That's what it takes to cure late Lyme arthritis. But most people are told you've had 2 weeks of doxycycline, you're cured. You're not getting any more antibiotics. There's no other infection in the world that infectious disease doctors refuse to treat patients for longer, except for Lyme disease. You use your clinical judgment for more conditions, but clinical judgment is out of the window when it comes to Lyme disease.
Why do you think that is? Because you were also describing that it's hard to get funding or publishing for Lyme research. Is it what do you think is going on with allopathic doctors and Lyme?
I don't know. I don't like to get into the conspiracy theory, but there's just, even when you prove that there's still Lyme persisting by PCR, in a joint, 6 months after treatment, the Infectious Disease Society of America will come out with a publication that say that PCR doesn't represent live bacteria. It's actually dead proteins of dead Lyme bacteria. There's seems to be a concerted effort on some people's part just to downplay the seriousness of Lyme disease. And there's all these conspiracy theories that some of these guys have patent rights on the standard Lyme antibody test, et cetera, et cetera. But it's a paradox to me because most of my colleagues treat bone infections and the guidelines say 6 weeks, but my colleagues treat people with bone infections sometimes for 6 months. So they don't follow the guidelines, they follow their clinical judgment, but clinical judgment goes out the door when it comes to Lyme for many clinicians.
So you mentioned there the original doctor who established the modern Lyme and his treatment with IV antibiotics. Do you think so? There was a question: is it better to have IV antibiotics or oral antibiotics for Lyme disease? That was a question we received.
Right. Well, the thing, if your gut can't absorb the antibiotics, you need IVs. But otherwise, you can get just as good bioavailability with oral antibiotics as IV antibiotics. And it's very difficult to get IV. It's complicated, it's costly. There's a risk of infections for IV cannulas, so and then second off, IV ceftriaxone, which is drug, only covers one bacteria. The advantage of some of the other antibiotics are, like I said, it's not just Lyme, it's Bartonella, it's Anaplasma, Rickettsia, Babesia. There's other bacteria called co-infections that can be there as well. So so I prefer, if people can tolerate it, just a longer course of oral antibiotics. That's what gets people better, not a short course of IV.
Okay, so that's great. Really, I think everyone's finding this really interesting. I certainly am. We're going to move on and talk about Lyme disease and COVID-19 and the interaction between those two. There was a lot of questions on this subject as well. So this is from somebody: does Dr. Lambert think that having Lyme disease leaves the body more vulnerable to developing long COVID after infection?
Well, interestingly, many people that get long COVID, women are more predominant than men for long COVID, because I think women have more autoimmune, pre-existing autoimmune disease. You know, they sometimes have dry eye syndrome before, they sometimes have, you know, lupus antibodies, you know, so women have more autoantibodies, and I think there's maybe something there that makes them primed to be more likely to get, you know, long COVID. But, you know, not necessarily so. You know, it's really unpredictable. I had a fellow the other day who can't remember his story, but yeah, he's got long COVID and perfectly healthy before. No, I saw him today. And he's out of work 6 months now, and he's a microbiologist. He was perfectly healthy. But then I said, "How about virus reactivation? Have you ever had shingles?" And he says, "Yeah, well, actually, I had 3 episodes of shingles in the last 10 years." So that's a bit unusual. You don't see 30-year-olds getting 3 episodes of shingles. I see AIDS patients, I see transplant patients getting that. So there may be something about him that made him more prone to develop long COVID, maybe something in his immune system. So we don't understand all the factors, but yeah, I think there is something that predisposes people. There's lots of people I ask, did you ever miss time in college? You know, there's lots of people who had Epstein-Barr virus, you know, kind of chronic fatigue syndrome, totally recovered, doing well, and then along comes COVID. Pow! I think their Epstein-Barr virus was, their immune system was controlling it. They're getting reactivation. And then they have some immune dysregulation as a function of Epstein-Barr. Epstein-Barr does cause immune dysfunction. Epstein-Barr does affect the mitochondria. It does affect the autonomic, you know, system, causing POTS and this and that. So I think sometimes people have a pre-existing condition and then the COVID will kind of trigger it. Similarly, like I said, I had patients who I thought had Lyme, recovered, and then they get COVID and all their Lyme symptoms come back. I had a kid who um, got COVID and then got long COVID and broke out in these Bartonella striae all over his body. So I think he had probably underlying Bartonella on top of, you know, the long COVID. So in some situations, there's something there. But previously 100% healthy people can get long COVID as well.
Good. So it definitely seems like COVID can Lyme can be reactivated after you have COVID. And I think you touched on there that you do think there is some sort of could be some interaction between EBV, Epstein-Barr virus, and all three of them, Lyme and COVID as well.
I think so, yeah. I mean, everybody has DNA viruses in their body, and they're supposed to be, your immune system's supposed to have them in your cage, in a cage, hidden away, not causing any trouble. But as I said, I just showed you that slide from the ICU. The lymphocytes were lower in patients who, you know, had reactivation of Epstein-Barr virus and CMV. And I have some patients running around with a CD4 count of 250. And if I showed it to my junior doctors in my public clinic, they say that person has HIV and AIDS. They don't have HIV and AIDS. They sometimes have chronic Lyme. They sometimes have long COVID. So these infections affect the lymphocytes. Lymphocytes are the white cells of the body that, you know, control your immune system, orchestrate your immune system, help you fight infections, help you control infections that are dormant in your body, and help you clear infections.
Sorry, a specific question about COVID now, just about teenagers and pandas in teenager. Please, can long COVID look like pandas in a teenager?
Absolutely. So pandas was first described, you know, neuropsychiatric manifestations in children, AS associated with strep. And we know that strep goes to the basal ganglia, and you can get movement disorders following a strep infection. And so pandas was first described following strep. But viruses can activate pandas. Epstein-Barr virus can activate pandas. Lyme can activate pandas. Bartonella can activate pandas. And I've seen some children now getting COVID-19 and then going on to develop tics, OCT, neuroinflammatory processes. So lots of different infections can trigger, you know, pandas, which is kind of a neuroinflammatory state, more commonly seen in kids and young adults.
And does a Lyme co-infection imply that a patient would have Lyme straight away? Does one follow the other, or can you have one of the other diseases from a tick without having Lyme? Or
Yeah, well, yeah, you can get a tick bite and just get babesia. You can get a tick bite and just get Ehrlichia anaplasma. In South Africa, they don't think there is any Lyme. People get tick bites all the time and they get scrub typhus. It's caused by a rickettsial infection, but they end up with chronic fatigue. They end up with a lot of the same manifestations. So there's multiple different bacteria that come from ticks.
Okay, great. We're just gonna check the sound and make sure everyone can hear us okay. Okay, we're moving on to long COVID symptoms and treatment now, which was another area that there was a lot of questions on. What is the best way to manage chronic fatigue from long COVID? I think you hit on some of those things in your talk.
Right. Yeah. I mean, there is no magic cure. Like I said, it is neuroinflammation. Sometimes the fatigue can be worsened by virus reactivation. My standard is LDN helps about 80%. It works on neuroinflammation. The brain fog lifts, the headaches go away, the energy improves. Now, it's not the magic bullet. It's not dealing with all the different five, pathogenetic mechanisms, but it's working on, inflammation, immune dysregulation. So that's one thing. And then the second thing is the fatigue can often be a function of, the mitochondria. So going on products that have NAC, I think is really important. Going on a probiotic that takes care of the gut, I think can be very important as well. And then you build from there. There's lots of other products that help. I sometimes even, there's some herbal products like Rhodolia rosea, which is Arctic root. Arctic root is used by physicians in Russia, prescribed to work on brain acuity, to work on mental function. So, there's no one magic cure, but the two things that I've, found really helpful for fatigue is LDN number one. Number two, obviously, is pacing, because what happens with people is the more they push, the more their symptomatology get worse. And if they crash, they end up taking a long time to recover. So it's a multidisciplinary, multifaceted, approach. But a minimum, I start people on a multivitamin with coenzyme Q10, LDN, something to make sure their sleep pattern is good, something to support their mitochondria.
So, and you were also mentioned because sleep, I think, and it's certainly a topic that comes up a lot of Napiers, the herbalist. You highlighted earlier on that people were there was alcohol misuse among sufferers. Do you
Yeah.
think that's to do with sleep as well? They're using it
Yeah.
for sleep, or?
Yeah, I think sometimes it's just to, look, I have so many patients that get this dysautonomia. They're in sympathetic overdrive. It's sort of like they've had 10 cups of coffee, and they're jumpy, they're nervous, they're anxious, they're worried about stuff they never did before. They don't have an anxiety disorder. They've got sympathetic overdrive, imbalance of the sympathetic parasympathetic system. And I think people try to find ways to cope with that. So sometimes alcohol can be a way to dull that, So it doesn't mean that people are becoming alcoholics or anything. It's just people are having neuropsychiatric problems they never had before. They're having PTSD. They're turning to things to kind of control the anxiety.
Okay, good. And then just a couple of ones. Can long COVID, do you see long COVID cause, because you did talk about the lungs being quite resilient to COVID, but can long COVID cause long-term lung problems? And have you ever seen, or what are your thoughts on lymphatic drainage to support recovery from long COVID?
Okay, so in the first wave, I've seen patients who were on breathing machines, on respirators. One of my colleagues, who's an endocrinologist, unfortunately has fibrotic lung disease, bronchiectasis, because he was caught in the first wave. So he's got lung damage. But as a rule, the lung heals. And very often people describe this gasping for air, this air hunger, and they're sent to pulmonary specialists. And it's the wrong model. Now, sometimes people have asthma and their asthma gets worse because of the immune mast cell thing following getting COVID. Some people have bad asthma and their asthma gets better following COVID when they develop long COVID. It's very unpredictable. But as a rule, I think the problem isn't, in the lungs. There's sometimes diaphragmatic paralysis, so some of these diaphragmatic exercises can be helpful, but most of the problems is brain signaling as opposed to primary, pathology in the heart, primary pathology in the lungs, and even the gut. You go to a specialist clinic, they'll give you a TAMRA test from top to bottom, endoscopy, colonoscopy, trying to figure out why your gut isn't working with long COVID. The problem is the innervation of the gut. It's the vagus nerve. It's the sympathetic parasympathetic system.
It's interesting this because I hadn't really appreciated the level to which inflammation in brains was causing such problems. Do you think there's so I suppose how do we get the inflammation down in the brain, and also do you see any hope for GLP-1s in treatment of this kind of stuff? Or
Yeah, there's lots of, theoretical possibilities of things that can be used, and in terms of modulating this. So, but time will tell. There's not a lot of studies out there. As I told you, I kind of gave you the review. There's only 18 studies out of thousands that have been reviewed. There's very few studies in the pipeline looking at how to manage, long COVID. But like I said, the neurorehabilitation model is the model, and herbs products that work on brain signaling from melatonin to serotonin to to IVIG, which works on some of the brain receptors. All of those things may have a role in getting people better.
okay, and this is a question for me. Is there any evidence of fasting to help with inflammation of the brain?
Yeah, I think, well, the thing is I'm not a dietitian. People ask me, should I change my diet? And I say 80% of your immune cells are in your gut. There's Polish people drink kefir, the best in Ireland, the best kefir you get at the Polish stores. And they've used it for a century for chronic fatigue syndrome and fibromyalgia. By manipulating their gut, their pains get less and their energy improves. So lactose free, glucose free, sugar free, all of these different diets and, do make a difference in neuroinflammation.
Good. That's been super, Jack. Dr. Jack Lambert. What we're going to do is we will be sending out an email to everyone who was part of tonight's webinar, and it will have all the links and everything in it, so you can rewatch the video. Jack, could you stay for another 10 minutes or something? Could we do a couple of questions, or do you have to rush off?
We could do 3 more minutes, but I need to get going. Okay.
Okay.
We'll do a few more
Jack's
questions.
we've got 3 minutes. If anybody quickly, we can try that. But we're literally going to get one, I think, done in time. Jack has to dash off. Let's see. I know there was some people that were keen to ask something because they came on and said, "Was there a question?" Here we go.
What you can do is you can actually, the questions aren't answered, send them to me and I will answer them by email and send them back to you. Maybe you can post them on the website.
Yes. Okay. That's what we'll do, because we've got some questions here about the exact dose of NAC. How long does it take? Well, here's a good one. How long does it take LDN to work, Jack? How quickly would you see that?
It can be 2 months. It can be a couple of months. That's the thing. It doesn't work overnight. And that's part of the problem. People say, oh, go 1 milligram for a week, go up to 2 milligrams, go up to 3, go up to 4.5 in a period of a week or two. I go very, very slow. And sometimes what happens when you go to 1 milligram to 2 milligrams, you get a little flare up of symptoms for a day or two, and then you see improvement. So, but it's a titration. I have people that go up to 2 milligrams and their headache disappears. And then they go to 3 milligrams and the headaches come back. And I go, your magic dose is 2. Stay at 2. So it's not, more is not necessarily better, like money in the bank, It's a qualitative effect. It seems to have some qualitative effect on the inflammatory receptors in the brain. So you go slow.
Good. Thank you very much, Dr. Lambert. We will have this published for everyone, and you'll get an email from us later on. But amazing. I think everyone's really appreciate your time. We know you're very busy, so we really appreciate it. And we look forward to seeing you again at Napiers sometime soon. We'll be coming back in the next few weeks with a herbalist to talk more about herbs and how herbs are being used for treatment in COVID, long COVID, and Lyme. Thank you so much, and we hope to see you again at Napiers very soon.